Good evening, everyone. I'm Dan Faulkner, Registrar and CEO at the Royal College of Dental Surgeons of Ontario. Thank you for joining us tonight. Welcome to this evening's RCDSO Connect session, IPAC and the Dental Office, Responding when a Lapse Occurs. This session has been approved for 1 point in Category 1, and as a reminder, participants are required to attend for a minimum of 40 minutes to be eligible for the CE point. As you know, RCDSO Connect is one of the ways we stay connected with the profession. These sessions create opportunities for shared learning and thoughtful discussion on issues that are fundamental to safe, effective, and professional dental care. This evening's session builds on the first part of our IPAC series, which took place on May 20th and focused on preventing IPAC lapses and strengthening a culture of safety in the dental office. Tonight, we will focus on what happens when a lapse does occur and the important role dentists play in managing the situation effectively. In March 2025, a dental clinic in Ontario was closed and thousands of patients were advised to see their primary care physician to be tested for hepatitis B, hepatitis C, and HIV. In November 2025, another clinic in Ontario was shut down by local public health authorities, and thousands of patients were notified in March 2026 with advice to be tested. While IPAC lapses remain relatively uncommon, and most are caught and contained early, unlike the two that I mentioned, their consequences can be significant. Ask a patient about the impact when they receive a notice in the mail in respect to a lapse and the advice to be tested, even if the risk is identified as low. The outcome of lapses will impact patients and also dental team members, and there can be reduced public confidence and trust in the profession and the system of oral health care. Responding appropriately requires sound clinical judgment, effective communication, collaboration with public health and regulatory partners, and a commitment to continuous improvement. Throughout this evening's discussion, we'll explore the provincial framework for IPAC oversight, the potential impacts of lapses on patients and families, and practical strategies for assessing risk, responding appropriately, and preventing recurrence. Our goal is to provide information that is both rooted in science and directly applicable to your practice. The college remains committed to supporting dentists in this work through standards, guidance, educational resources, and continuing professional development opportunities. Together, these efforts help strengthen patient safety and foster a culture of accountability and learning across the profession. Please feel free to submit your questions throughout the session. We can't answer all of them, but we'll do our best to address as many as possible during the discussion. And we'll be reviewing all of the questions submitted during the May 20th and tonight's session over the coming weeks, and working closely with our partners at the Ministry of Health, Public Health Ontario, and local public health units to address them. Responses may be provided through FAQs on our website, links to existing resources, or new resources developed to support the profession on this important issue. We'll also share an update in our fall issue of the RCDSO Connect magazine. Before we start our discussion, I'd like to recognize the privilege of gathering online this evening by sharing a land acknowledgement. We begin each Connect session with a land acknowledgement because it is an important reminder of the histories, relationships, and responsibilities connected to the lands where we work and provide care. It reflects our ongoing commitment to reconciliation and advancing equity in oral health care. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto was covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity, and we embrace our role in regulating dentists, in protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe, equitable oral health care. Thank you. Now I'd like to introduce our presenter, moderator, and panelists for the evening. We'll begin the session with a presentation from Dr. Kate Bingham. Dr. Bingham is an Associate Chief Medical Officer of Health for the province of Ontario and was previously an Associate Medical Officer of Health in Peel Region for 9 years, including serving as the Acting Medical Officer of Health. Dr. Bingham will provide an overview of the provincial legislative and regulatory framework that guides oversight of infection prevention and control practices, including the investigation of concerns and complaints. Our discussion this evening will be moderated by Dr. Sonika Singhal, Assistant Professor and Program Director in Dental Public Health at the University of Toronto's Faculty of Dentistry and Public Health Dentist with Public Health Ontario. Joining Dr. Bingham on the panel are Dr. Joanne Fernandez, Associate Medical Officer of Health at York Region Public Health, Dr. Herveen Sachdeva, Associate Medical Officer of Health with Toronto Public Health, and Dr. Helene Goldberg, Senior Dental Consultant and Team Lead at the RCDSO. Their perspectives will help ground tonight's discussion in practical experience and real-world situations that dentists may encounter in practice. I'll now turn things over to Dr. Bingham to begin the session. Dr. Bingham.
Thanks very much. So I'll start us off with a brief presentation and just to give us some grounding in the framework and the structures of public health in Ontario and how IPAC and IPAC lapses fit into that. Next slide, please. Just to share that I have no actual or potential conflict of interest related to this presentation and a request to please not copy or reproduce the presentation without consent from the ministry. Next slide, please. So as I said, the purpose of my presentation is to describe the overall public health system and the legislative framework for public health in Ontario, and to provide an overview of the roles and responsibilities for public health units, or PHUs, and their investigation process for infection prevention and control lapses. Next slide, please. So this slide describes the requirements that public health units must follow for public health overall and shows how IPAC fits into that. The Health Protection and Promotion Act is the main body of legislation that guides the work of public health in Ontario. It outlines the roles and authorities of some of the key stakeholders in public health, such as the Minister of Health, the Chief Medical Officer of Health, as well as local stakeholders such as public health inspectors and the medical officers of health of each public health unit. The HPPA also provides the legislative framework for enforcement measures, for example, health hazard orders or Section 13s, or communicable disease orders under Section 22, which can be issued by the local medical officer of health or a public health inspector. When it comes to enforcement measures, though, in public health overall and not just in IPAC, we typically focus on a progressive enforcement approach, where education and collaboration and remediation are really the focus, and enforcement is used as a last resort. The Ontario Public Health Standards then outline the mandatory programs that the public health units must provide in each part of the province. In the diagram, you'll see a sort of schematic for our Ontario Public Health Standards, and the outer box displays what we call the foundational standards for the programs that must be delivered. And those standards include population health assessment, which speaks to the need to understand your local population and their specific health needs. Health equity, to ensure that public health programs are supportive of everyone and aim to reduce inequities. Effective public health practice, which aims to ensure that public health units are making decisions based on the best available evidence and in a transparent way. And finally, our role in emergency management, to ensure public health units maintain their capacity to respond to new and emerging public health threats. You'll see then the inner circle of the diagram shows the program standards that are a part of the OPHS. These are quite broad, but they're all focused on improving population health outcomes, and IPAC, or IPAC lapses, fall under the program standard of infectious and communicable disease prevention and control. So it's really one small part of the broad work of public health, but obviously a very important one in terms of health protection. Next slide, please. So staying on the Ontario Public Health Standards and speaking specifically to IPAC, there are 3 different IPAC protocols that public health units must follow. So this informs, I think, for this audience, where there are some things that, while the approach may be flexible, there are some requirements that health units must actually follow because of the protocol and the overarching legislation. These protocols outline the frequency of routine IPAC inspections, and these are in settings such as personal service settings and childcare settings, and then how to respond to an IPAC complaint from the public in any setting, and how to disclose the results of routine and complaint-based IPAC inspections and investigations. Next slide, please. Moving from the standards on the paper and the legislative framework, just to speak a little bit about how this then translates into role. So this shows another way to think of the public health model in Ontario. The key stakeholders are the Ministry of Health, Public Health Ontario, and then the 29 local public health units across the province. The Ministry of Health and the Chief Medical Officer of Health, who's within that, provide leadership on public health issues as well as policy direction. The work of public health units is guided by the Ontario Public Health Standards, which we've just discussed, and their related protocols. Public Health Ontario is a government agency who provides the scientific and technical expertise to guide public health unit decision-making. They also provide laboratory services and research to support public health units and the public health system overall in Ontario. Public health units are responsible for actually providing the services and programs to their local communities and are very tightly aligned with the partners across local communities, all of those partners that impact health. They focus on population health, health promotion, and disease prevention in accordance to the Ontario Public Health Standards that I've referred to already. More information on the public health role and investigative process is going to be discussed in the next couple of slides with respect to IPAC lapses. But all of these three key partners collaborate with one another to support public health in Ontario and improve the health outcomes of the populations they serve. Next slide, please. So I'm going to move on to a very high-level approach to the public health role in IPAC investigations. And you'll see through the cases that we work through, the panel works through after, that there's some variation across the province based on all the various factors that might be at play in an individual complaint or investigation. But at a high level, it's probably helpful to think of it in 4 steps. So the first phase would be that a health unit might receive an IPAC complaint from a variety of sources, and these include a complaint from the public. There may be a complaint from employees within an office or former employees, a complaint that's referred from the regulatory college, and then the public health unit needs to determine the appropriate response to that complaint. So the next step would be that an investigation may be conducted if the complaint reaches that step. A public health inspector would conduct an investigation to determine if an IPAC lapse actually exists. An IPAC lapse is defined as a failure to follow IPAC best practices resulting in a risk of transmission of infectious disease. The public health inspector also has the option to conduct the investigation and the inspection with a colleague, such as a public health nurse, for example, a complaint that was specifically related to medication administration, or with a public health dental hygienist or dental assistant, for example, in a dental clinic inspection as needed. And the inspection or investigation team will vary based on the nature of the complaint, the nature of some of the initial findings, and also the local context of the local public health unit and where the expertise lies in their staff. Next, the public health inspector will provide education to the operator in the setting if any IPAC issues are observed, and corrective actions under the HPPA might be ordered by the public health inspector if warranted. And that might include orders under the HPPA. And again, those are quite contextual, whether those are issued or not. And then finally, the public health unit will need to disclose the lapse according to the lapse disclosure protocol. That typically means that the public health unit will post the lapse on their website, and IPAC complaints that are not substantiated don't need to be posted online. So next, I'll go back through this process and the steps and talk about what this might look like in general in a dental setting. So next slide, please. So what a dentist can expect at each of these stages. So at the level of the initial IPAC complaint response, the office would receive an inspection during operational hours. Usually these inspections are unannounced, and it will be conducted, as I said, at minimum by one public health inspector and might also include other staff from the public health unit. Once the investigation begins, the office inspection would involve the public health unit evaluating the dental office's IPAC practices to determine if a lapse has actually occurred. And common tools that are used at this stage by the public health units are Public Health Ontario's IPAC checklist for dental practice, for example, the core elements checklist and reprocessing checklists. If non-compliance is observed by the public health unit, then the dental office staff will receive education from the public health unit. The office staff must correct any issues that are identified, and the public health unit may or may not issue enforcement action under the HPPA. And then finally, at the stage of disclosure, if an IPAC lapse is identified, the dentist should be prepared to review and provide patient records to the public health unit so that patient notification can occur if it's determined that that is necessary. And a plug here to say that high quality patient records help better determine if previous patients have been exposed and are at risk. So both patient records and records of all of your IPAC practices. Next slide, please. So finally, how we collaborate across all of the partners here on this call and many others to help keep patients safe. We really do have a shared mandate to protect the public. IPAC education and accountability is a shared issue between both public health units and the public health system in general and the college. And both parties are involved in IPAC education for providers and enforcement of best practices. In terms of information sharing and then collaboration between public health units and regulatory colleges, public health units are required to notify the appropriate college when there are concerns regarding a regulated health professional's practice during an IPAC lapse investigation. Under Section 36 of the RHPA, regulatory colleges are able to share information when it is required for administration of the HPPA. And then correspondingly, there is language in the HPPA that allows for information sharing when it is concerning a risk of or a disease of public health significance. Next slide, please. So a few key takeaways, and then hopefully we can apply some of this in a more practical way through the cases. So the main takeaways are that the public health units do have a very broad and diverse mandate that focuses on improving and maintaining and protecting the population's health overall. And IPAC lapses and IPAC practices in general are part of that mandate. Public health units are responsible for investigating IPAC lapses in various settings, including those where dental professionals work. And public health units are encouraged to collaborate with the Royal College during an IPAC lapse investigation that involves a dentist. Dentists, for their part, can assist in minimizing IPAC lapses by following the most up-to-date IPAC guidance from the regulatory college and your workplace. And Public Health Ontario has great resources to support that as well. Having clear roles and responsibilities for dental office staff, for example, with respect to reprocessing and patient record keeping, and ensuring that those are reviewed and refreshed on an ongoing basis. And then ensuring that records are accurate and complete, both patient records and the records with respect to reprocessing, for example, and other IPAC practices within the office. IPAC lapses can lead to disease transmission and outbreaks, and as we were talking about at the beginning of the session, the loss of public confidence and strain on the overall health system are things that we'd all like to be avoiding if at all possible. Next slide. You can reach our team at this email address within the Office of the Chief Medical Officer of Health in the Ministry of Health. We're here to support. This truly is a team sport, and we're happy to answer any questions related to our parts. I'll pass the mic back and we'll move on to the next section.
Thank you so much, Kate, for your insightful presentation. It really helps situate our discussion about how the various legislative and regulatory elements fit together in terms of IPAC investigations. As we move into the panel discussion, we will explore a few scenarios to illustrate what happens when a public health unit receives a complaint about a dental office. In our first scenario, a public health unit receives a complaint from a former patient of a dental practice stating that the office is not clean, has dirty floors, and overflowing waste baskets in the patient rooms. My question to you, Joanne, can you describe for us how that type of complaint might come to the attention of the local public health unit? And then can you walk us through how the public health unit would respond?
Sure. Thanks so much for the question, Sonika. So first, I just want to note that the approach that I'm about to describe may vary from public health unit to public health unit in terms of what happens with respect to the risk assessment once the complaint is received. Health units can receive all kinds of complaints from patients who are upset about services being provided and bedside manner. And obviously, we only follow up on the ones that are in our purview to deal with from an IPAC perspective. But typically, we'll receive calls from patients, from staff, from former staff. And usually these come in through our phone line where they are vetted by our public health inspectors. And there's some intakes that are asked, intake questions that are asked of the complainants to understand a bit more about the complaint that's being received. So in this case, for example, did they see blood? Was there concern about any of the devices or equipment or tools that were used? Because when we think about this particular complaint, about the lack of cleanliness, there really aren't a lot of IPAC issues that are apparent at first glance. That said, for us at York Region, we probably would do an on-site investigation in this scenario, given it is a clinical setting. And sometimes these complaints can be indicative of other issues that may also be going on. So in terms of next steps, usually there's a bit of an internal discussion that happens within our IPAC team. In this case, a public health inspector would typically go out to the premise after some consultation with an IPAC specialist and our program manager. If there are things related to medication administration issues or specific reprocessing concerns, then the IPAC specialist would go out because they do tend to have a bit more specialized knowledge in these areas. And as Kate said earlier, when the public health inspector goes out, it's typically unannounced. There's no coordination that happens with the clinic prior to the visit for obvious reasons. And once we're on site, we do tend to focus on the complaint that was provided, but if obvious issues related to IPAC are seen while we are on site, then the scope of the inspection may change accordingly. And another plug as well, we will often use the Public Health Ontario checklist to guide our inspection, which again, I want to highlight, as Kate did, as a really great resource for dentists to be aware of and to kind of refer to.
Great. So like in this situation, the public health unit does not find any IPAC lapse, only issues around general cleanliness. So Joanne, can you tell us what happens next?
Yeah, so maybe I'll start with talking about what some of the pieces may happen that may happen if a lapse was found. So if there's a lapse, typically we would report this to the provider's respective college. So in this case, it would be the RCDSO. We would also post the details of the lapse to our website, which is done for the purpose of transparency to the public. But in this case, because a lapse was not found, the issues were related to general cleanliness and not much more, that reporting wouldn't happen. So it wouldn't be reported to the RCDSO and the lapse wouldn't be posted to our website. In addition to this, and noting again that, this part may differ from public health unit to public health unit, but our practice at York is to leave or to provide some sort of report, even if there's no infractions or if it's just minor issues. And we would encourage staff to review any areas of concern. And this would be a really good opportunity, I think, to have a conversation, about IPAC with your team, to review roles and responsibilities, to ensure training and all those pieces are in place. And from the public health unit side, if the inspection just showed minor issues, we typically wouldn't conduct a reinspection. So we would leave things there at that point.
Okay, great. Thank you so much. Now let's discuss a scenario where a public health unit receives a complaint from a former employee of a dental office. And similar to the previous example, the public health unit would conduct an investigation. Only this time, numerous IPAC issues are found, including reprocessing issues. So the health unit determines that an IPAC lapse has occurred. My question to you, Herveen, can you provide some insight into what the next considerations are for a public health unit once a lapse is confirmed?
Sure, thanks. Thanks very much, Sonika, and thanks for having me here tonight. So in this scenario, the health unit has confirmed that a lapse has occurred involving reprocessing. And so the first thing that's important, well, there's kind of three initial things that we're thinking about if we find a lapse. Um, the first thing is mitigation, and the second thing is remediation, and then the third thing is a risk assessment. So I'll go through all of these three things in detail now. So first thing in terms of mitigation, the first thing that comes to mind is to think about, we know this lapse has happened. Is it something that's happened in the past? Perhaps this is a report of something that happened last week. We noticed that the sterilizer BIs failed, but someone didn't check them. Or is it an ongoing risk? So, as Joanne mentioned, we've sent our inspector in, and what they're observing right now during practice is presenting an ongoing hazard. So, the first thing to do that we want to do is just stop any ongoing risk. And so that's what I mean by mitigating that any hazards. And in a dental office, it really would depend on what can continue safely based on the reprocessing and what needs to stop. Are there patients booked and there's certain instruments that just can't be used? And as much as possible, the local public health unit in our practice is to really try to minimize any disruption to practice, but make sure that on any ongoing practice is safe. As we all have been talking about, patient safety is our shared goal. And so certainly, we know it's very disruptive to stop practice. Patients are booked. But again, our primary role is to make sure that there's no ongoing risk. And so we'd work with the office to say, okay, these tools, because of these reasons, have been affected by the lapse, and that involves these procedures. So these things need to stop right now. And hopefully that's not the entire practice, but in some cases, depending on the setting, depending on what's happening and the lapse, it might be the entire practice. And so in those situations, we'll work with the office to say, these are the things that need to stop. Oftentimes, that can happen as a conversation and a recommendation. Uh, as I think Kate and Joanne mentioned, there are the powers within the public health inspectors to issue an order under the public health legislation, the Health Protection and Promotion Act. But again, depending on the situation, we often don't need to issue orders. It would only be if we really found something like there's a real disconnect between uh, a level of confidence that people can get up to speed very quickly. So in some situations, an order may be issued, and that's part of the legislative powers that the public health inspectors do have. So that's the first step, is to just mitigate any risk. But again, oftentimes it could be, this disinfectant wasn't being used appropriately, or you don't have the right disinfectant. Can you go out and get it, depending on the setting? And then in that situation, practice can continue, no need for orders, and the hazard has been mitigated. So that's the first step. The second step is to think about remediation. And so in the situation you described, it sounds like there might have been multiple steps in reprocessing. And even as Joanne had mentioned in her scenario, sometimes these things are not isolated. You see problems with reprocessing. There might be problems with policies and procedures. There might be problems with other aspects of practice in IPAC. And so again, it's thinking about taking a step back and making sure that there's clear recommendations so that the practice can get up to compliance and be in best following best practices in all these different areas. And so the public health unit and the IPAC team will work with the office. Often will leave a letter of recommendations. Oftentimes there's more than one or two communications in terms of emails, phone calls, a follow-up inspection, as Joanne mentioned, to make sure that the IPAC practice is remediated. So that's the second step. And the third step that's important with an IPAC lapse, and so in these scenarios, that's where we are thinking that there may have been a risk of disease transmission. So then we have to, again, do a little bit of thinking internally at the local public health unit in terms of the risk and whether patients may need to be notified. And I think when Dan started the session, he did highlight some of those, offices and larger patient notifications that have happened. So that risk assessment process happens at the local health unit. Sometimes they'll consult with our partners at Public Health Ontario and ask for a formal risk assessment depending on the nature of the lapse, what we're seeing, what the evidence shows us, to really make sure that we're giving the best advice to the practice and also making sure that we're giving the best advice to the patients who may have been affected.
Thank you so much, Irene. That was very insightful for all the details you provided. So now with the same scenario, let's pass it to Helene from the college. Helene, can you please share RCDSO's perspective and action in such scenario? Like what happens at the college following a report received from the public health unit?
Thank you, Sonika. As Kate and Joanne and Herveen mentioned, public health notifies the college of all IPAC complaints involving dentists. Notification from public health can occur at any stage, at the beginning of their investigation, mid-investigation, or at their conclusion. Public health typically provides the college the nature of the IPAC complaint, the office address, and the name of the dentist or dentists involved. I say dentists because all dentists, including associates working at a location, are responsible for the IPAC in the office, not just the practice owner or if the duties are delegated to another oral healthcare worker in the practice. Upon receipt of the information, the college typically requests the following from public health: inspection reports, a detailed list of IPAC deficiencies found at their on-site inspection, along with those that have been corrected and those that remain outstanding, whether an IPAC lapse was identified or there's patient notification, along with if public health is attending the office for any follow-up inspections and when public health's investigation is closed. The objective is to gather as complete a picture of all of public health's findings and risks to the public. Based on the information received, the college may request a voluntary response from the dentist based on the information provided from public health. The dentist should retain all documentation, including emails, letters. I know letters of recommendation are sometimes provided, and reports that public health provides for their own records, as this information may assist in responding to the college. Once the information gathering is complete, all materials are reviewed with respect to the dentist IPAC compliance. From there, there's a few different outcomes are possible depending on patient risk. The college may close the file and take no further action beyond monitoring the dentist's response to public health and the response to the IPAC lapse if one occurred. The file may be closed, in which there could be a case the dentist may receive a letter from the college with some IPAC recommendations, or the registrar may investigate the dentist regarding IPAC compliance. The overall focus is ensuring patient safety and assessing the compliance with IPAC standards. Thank you.
Thank you so much, Helene, for your input. Moving along in our same scenario, the next question is for Herveen. How does the public health unit determine what actions should occur next? Example like patient notification or media notification. And let's assume that the public health unit has in fact determined that patient notification will be necessary. So how does the public health unit work with the dentist to conduct patient notification? And how does the health unit determine a method of doing this? If there are too many questions, I can repeat. That's okay.
Thanks, Sonika. So from what I understand, it's how do we work with the office in terms of, so patient notification's been decided, and then how do we work with the dental office? Thanks. So yeah, there's many ways, and certainly the best strategy for us is to have very close collaboration because these are patients and they want to hear from their providers. So our first, we work very closely with providers in these scenarios and um, understand, we hope it never happens, but certainly that's a support that your local public health unit will provide for you. And so one example is, again, it might just be we'll get a call from an office and they'll tell us that, they've been informed that a problem happened with the sterilizer that day and it's the end of the day and what do we do? So that is for us, it's a simple thing in terms of being able to say, okay, well, for those people, we would look at, again, we've made a decision that the patient notification needs to happen for certain patients based on the procedure. And really, we can provide a script because, again, the best thing is for the dental provider who did the procedure. That's who the patients want to hear from. And maybe, again, you might be in a situation where it's multiple dentists or associates working in a practice, but people want to hear from the provider that worked on them. And so, again, we would provide a script and, basically outline that this is how the communication should happen and even templates and how patients could be referred back, though, to their primary care provider to get testing for bloodborne diseases if that's the scenario and that's the case that we've decided on. Where it gets a bit more tricky is if the lapse has been going on for several months and it affects a large volume of patients. So in those scenarios, oftentimes it's a matter of capacity at the dental office. It could be an option, but oftentimes they'll look to the public health unit because then you're looking at thousands potentially of people that need to be notified. Um, and so oftentimes we will work collaboratively with the office to do patient notification by mail. And in those scenarios, though, we often will share the advanced notification with the dental office so that they know exactly what we're telling patients, but it's a very similar scenario in that patients are being referred to their primary care provider. The third scenario is a scenario that we don't want to use, but sometimes we need to use, and that there might be a very large volume because the lapses have been happening for many years. And people might have seen some of these in the media. In those scenarios, oftentimes it is best to use the media just because there aren't necessarily up-to-date records of addresses on patients who have moved because we're talking about a very long period of time. And or if there's poor record keeping in the office itself, there's not an easy way to pull the information because there's not an electronic medical record. Nor do we have confidence in the information, in the documentation. So in those scenarios, we may have to go to the media, which is not an ideal form, but again, we would work with the office to make sure that the messaging and the risk communication is done as best as possible.
Thank you so much. That was very insightful. Back to Helene. When public health unit identifies that patient notification is required, what are the dentist responsibilities?
So when an IPAC lapse is identified and patient notification is required, the dentist remains responsible, regardless whether public health or the dentist sends out the notification, or even if it's in the media. The dentist must cooperate with public health, support patients, and be available to answer any questions. It's critical that a copy of the notification sent to each patient is placed in the patient's chart. In addition, all telephone calls or in-person communication, both to and from patients related to the notification, must be documented in the patient chart, including any key details of the discussion. This reflects the college's expectation for accurate, complete record keeping and accountability to patient care. The notification letter that is sent out to the patient is not the end. The dentist must ensure proper documentation and ongoing patient support. Thank you.
Thank you so much. Now my question is for Joanne and Herveen. What are the top 5 most common infractions you would expect to see in a dental clinic? Joanne, maybe I can start with you, if you don't mind.
Sure. Thanks, Sonika. I think for me, we often see a lack of what we in public health call administrative controls. So a lack of policies and procedures for things like reprocessing and sterilizing equipment. And in addition to that, inadequate training of the people who are tasked with doing the reprocessing, which is such an important piece of maintaining good IPAC practice if you as the dentist are delegating these activities. And important also that these policies and procedures are specific to the equipment that you have in the clinic rather than sort of generic policies and procedures on reprocessing. The other big one that we see is improper reprocessing steps and technique. So for example, the reprocessing area is not optimal. It doesn't maintain what we call a one-way flow. The cleaning is not done appropriately. So for example, we see manual cleaning happening rather than mechanical cleaning, which is really something that should be happening in a setting where there's such a huge volume and complexity of instruments being reprocessed. So those would be the 2 for me.
I'm happy to add on and agree with points that my colleague mentioned. Adding on to reprocessing, a big one is the quality monitoring of the sterilization process. So it's not just enough to have the sterilization, but making sure that it's being monitored with the biological indicators, chemical indication. So having that quality assurance is really important. Another thing that's really important is every piece of equipment has MIFU, the manufacturer's instructions for use. And in that, they will say oftentimes how to reprocess. And so just making sure that those manufacturer, like how the instrument was intended to be used and reprocessed, it's being used and reprocessed. And then related to that is sometimes even we're seeing items that are supposed to be single-use items, but they're being reprocessed. And if we are looking at the manufacturer's instructions for use, it would, is it a single-use item? It's single-use. Is it supposed to be reprocessed? How should we reprocess? And so, yeah, those would be some of the big common things that we see.
Thank you so much, Joanne and Herveen. Back to Helene. So what are the dentist obligations to prevent or mitigate these issues?
So infection prevention and control is a professional obligation for all dentists working in a practice. So this includes not only just the practice owner, but all associates, even if they work in the office once a week, once a month, or occasionally, and even if a dentist is working as a locum in an office for a short period of time. Instrument reprocessing duties can be delegated to a trained oral health care worker in the office. However, accountability cannot be delegated. All dentists practicing in the office are responsible for the well-being and safety of every patient they treat. This includes ensuring that all instruments that each dentist uses on their own patients are properly sterilized, safe, and support the delivery of safe patient care.
Thank you so much, Helene, and I completely agree with you. It's not about being a primary dentist, associate dentist. It's about the provider-patient relationship, and it's the provider's responsibility for safe care. So thank you so much for that. So I'd like to use our last couple of minutes for each of you to share one piece of advice in a rapid roundtable wrap-up. Tonight's session was titled IPAC in the Dental Office, Responding When a Lapse Occurs. If you could ask every dentist to do just one thing in their office to prevent or mitigate an IPAC lapse, what would it be? And I may start with Joanne again.
Yeah, I think my piece of advice would be to really ensure adequate training for reprocessing and sterilization. Just as I mentioned, given the number of tools that are used in a dental clinic, the invasiveness of procedures, really this is the foundation for everything and anything that could go wrong with respect to an IPAC lapse.
Maybe Harveen can go next.
Yeah, sure. So building on Joanne's, I will say, so in the training, making sure that the staff know to review the manufacturer's instructions for use of the equipment and the reprocessing, because I agree, reprocessing, training, understanding the MIFUs, all goes hand in hand. Thank you.
Great. How about you, Kate?
I'll add that this is often a team sport, right? Healthcare and dental care, we work collaboratively in all of our professional settings. And so, where while the ultimate responsibility lies with the dental professional in this instance, there are many people involved in many steps, but it's never a one and done process. So to be sure that there is a clear plan to regularly review, regularly ensure that training is happening, and to have that ongoing quality improvement and quality assurance focus on the IPAC practices within your setting.
Bang on. And last but not the least, Harveen.
Thank you. I agree with everyone on this call. I also want to add, as a last final safety check, the dentist should review the chemical indicators before opening the packages in front of the patient. And this is to ensure that all sterilization parameters have been met. I also want to add, if there is an IPAC lapse in your office, the important thing is not to panic. You have supports. So contact your local public health unit right away. Public health will support the dentist and the practice to ensure the patients and the public remain safe and that your office is in compliance with IPAC requirements. You can also contact the college's practice advisory service for guidance. Thank you.
Thank you so much for reassuring dentists that they should not be afraid of, anything. Mistakes happen, things happen, but then be open and talk about it. I think that's really important. So thank you for stating that, Helene. And with that, that concludes our panel discussion. Our conversation has reinforced key principles of IPAC and drawn attention to the critical role of the dentist as leader in creating a culture of safety. I will now hand it back to Dan for closing remarks.
Thank you. And this has been really an incredible amount of expertise and experience on one webinar. And I want to sincerely express on behalf of the audience and the RCDSO my thanks to our moderator, Dr. Sonika Singhal, our presenter, Dr. Kate Bingham, and our panelists, Dr. Joanne Fernandez, Dr. Harveen Sachdeva, and my colleague, Dr. Helene Goldberg, for a very thoughtful and informative discussion this evening. You've heard a lot this evening, and you've heard about the overarching legislation, about the need for effective communication by all parties, what collaboration looks like between public health, regulators, dentists, and clinic staff, and how a commitment to continuous improvement helps all of us understand what happened, why, and what can change to prevent it from happening again. And I want to acknowledge as well that the vast majority of dentists and practices are responsibly implementing IPAC practices. And what I'm about to say may surprise you. If you identify a lapse in your sterilization process, you quickly contain it, and you take instruments out of circulation, you communicate internally and with your local public health unit and the college, and you collaborate to understand what happened and commit to improve processes, the college will thank you and acknowledge your professionalism. Human error happens. It's what you do afterwards that demonstrates professionalism and accountability. So we sincerely appreciate the time and expertise of our guests who have joined us this evening, and we thank everyone who has joined us in the audience as well. As a reminder, you do not need to do anything to receive your CE certificate for this Category 1 session. We will use the attendance records from Zoom and issue certificates following the session. As a next step, We encourage you to continue your learning through the RCDSO IPAC Learning in Action Toolkit. The toolkit includes self-study and team-based activities designed to strengthen your office's culture of safety and support ongoing practice improvement. You are eligible to earn Category 2 CE points through these activities. Activities include reviewing the RCDSO's infection prevention and control in the dental office standard of practice, discussing toolkit resources with your team, completing the IPAC self-audit review, and sharing recordings from this IPAC series with colleagues in your practice. I'm also pleased to share that the college will be launching 2 new Category 1 continuing education opportunities later this year. Fundamentals of Infection Prevention and Control in September 2026, and Applied Infection Prevention and Control in November 2026. As I mentioned earlier this evening, we've also been carefully reviewing the questions submitted during both today's session and the May 20th IPAC session. We're developing additional resources and guidance to support dentists in practice. We look forward to sharing more information about those resources in the coming weeks and months. And as always, if you have practice-related questions following tonight's discussion, I encourage you to reach out to the college's Practice Advisory Service. You can also visit the college's website for additional resources and guidance. Thank you again, everyone, for joining us this evening. Have a wonderful night.